So now comes the blood gas analysis. It's very difficult to cover each and everything here, but and what I would like to tell you guys is, and with respect to the respiratory system, the blood gas analysis, most of you are aware that the pH, the PCO2 levels, like PO2 levels, the focus on it actually tells us like mainly on the oxygenation and ventilation. So with respect to the respiratory system. So if at all, if you have patient with hypoxemia, it can be because of these 5 causes: the hypoventilation, ventilation perfusion mismatching, the right to left shunt, diffusion limitation, diffusion perfusion mismatch. So when you start treating the patient with and the hypercarbia, type 2 respiratory failure, and you should actually see the corresponding in the pH in the patient. So better to treat the pH, not the PCO2 number, because the patients with the underlying and the lung disease like COPD, asthma, or interstitial and the lung disease or obstructive sleep apnea, there the basal, the CO2 levels, it can be on the higher side. It can be 60 or 70. So don't treat the number there, treat the like pH, and also see at the patient about the breathing, whether the patient is conscious or like drowsy. Depending on that, you can actually decide that okay, the patient is better or not improving. So this is the table, so which actually that tells us if at all if the patient has a type 1 the respiratory failure, pH it can be normal or high, the PaO2 will be like on the low, the bicarbonate will be low, the PCO2 can be the normal or low. If the patient is the tachypneic, the PCO2 can be low. Acute type 2 respiratory failure, the PCO2 will be high, bicarbonate will be on the normal or slightly increasing. If at all, if the most of the time, so we come across these patients, acute on chronic type 2 respiratory failure, see at the CO2 and also see at the bicarbonate levels, so which will be around like more than 30 or 35. For example, so and you have a patient with a 75-year-old gentleman who is in the background of like a smoker and admitted with acute exacerbation of like COPD. He's like drowsy. His PCO2 is around the 110, pH of like 7.19, the bicarbonate of around 38. So this looks like it's a chronic type 2 respiratory failure, but the patient is like drowsy. So because of that, so we'll start the like patient on NIV support for like 4 hours. And after that, so you repeated ABG, the pH is like 7.39, the PCO2 is like 70. So that means the patient is actually better. Here, the PCO2 is like still on higher levels, but for this patient, it can be on the normal and the basal levels as well. So always look at the patient ecosystem, like sensorium, PCO2 levels, like breathing pattern, and the heart rate, the BP, and all that. Depending on that, decide. Don't read the numbers. So after this, I think the pulse oximeter and the ETCO2 and the ABG now comes. So NIV support. So I go with like both with like monitoring and the support for the non-invasive now. So indications, and you all know it will be type 1 and the type 2 indications: acute pulmonary edema, the patient with mild ARDS, and patient with pneumonia and the immunocompromised, and most and obstructive sleep apnea, acute exacerbation of like COPD and all that. And the response to NIV support. See, whenever you start the like a patient on NIV support, like please explain the like a patient that you're going to like start the patient on NIV with like mask, which might be suffocating and for him initially, but later on he'll be able to accommodate it, and then see for the FiO2 levels, and see start the patient on NIV support with FiO2 of like 1 initially, and then slowly come down and see the target and the saturation like for that patient, how much it is required. So depending on that, tighter the SpO2 levels, and then comes on the weaning. If at all, if the patient is actually not responding to the commands even after like starting NIV for like 2 hours, it means like CO2 is actually building up or hypoxia is like and worsening. So it means NIV failure. So you might have to intubate the patient. So in those patients, so how do you monitor these patients on NIV? So look for the like strap and the tightness. All these called the under straps. So if at all if like started the patient on NIV, see whether there is any leak because and the straps are not and the binded and the properly, and most of the time it is on the single limb. There can be on the double limb on the circuits as well for the specific companies NIV. So please make sure that you should be aware for that gadget of that company, know whether it's a single limb or double limb circuit. The titration of FiO2 as per the target SpO2 levels, and that's like formula according to the age as well, and the tidal volume. So this is and the most important. So whenever you start the patient on NIV with type 2 respiratory failure and who has a CO2 of around 110 or 120, you please make sure that you stand on the bedside and see how much is the tidal volume is actually generating with the inspiratory positive airway pressure and also expiratory positive pressure. So if the tidal volume is at least around more than 250 to 300, that means the CO2 is actually going to come out. The hypercarbia will reduce. If it is still around 100 or 150, is still going to retain the CO2 level. So when you start the patients on NIV, giving a support and the monitoring, it happens on the same way. So start the patient on the IPAP of around the 12 or the 14s and see at the tidal volume. If it is more than 250 or 300, so and keep seeing for the next at least under 1 hour. So repeat ABG and see. If you feel the CO2 is coming down, if the tidal volume is better, patient can become fully conscious, and then after 2 hours give a break and start him again on NIV support and assess the effectiveness. So with the PCO2 levels, the respiratory rate, and the sensory. So an invasive ventilator, so we all know. So in the lung protective ventilation, so it is if I talk about the ARDS, it itself will take 1 day. So but here we'll go as simple as possible about monitoring and the support and the low tidal volume ventilation. So where we will set the tidal volume according to the predicted and the body weight. The body weight is according to the height of the patient. It is not on the weight of the patient. It is height of the patient. So why height is important? Because height actually tells us about and the lung and the dimensions as well. So with that, so if somebody is around the 170 centimeter, on the lung dimensions also will be according to the 170 centimeter. Though is on the 170 centimeter, if he's hardly around 60, 70 on the kgs, and the lung dimension also it will be the same for him. So but if somebody who is around under 110 centimeter, if he's around 200 under kgs, lung dimension also it will be the same. So for the predicted and the body weight, it is on the height of the patient, and we should actually put on the set the tidal volume here as per the predicted and the body weight. And FiO2 as well, keep doing in the titration and check the lung compliance. If you can see on this on the ventilator and the screen, so we can see the patient is on the PRVC and mode of ventilation. So with FiO2 here, the respiratory rate, the PEEP, and the tidal volume. So the same thing, it is actually seen in this and the scalars here. So we'll come to scalars and the loops as well in some time. So but here, so we can actually see how much the tidal volume will be under delivered, peak inspiratory and the pressure, the P plat and the compliance as well. So with that, and we'll do and the monitoring for all this in the patient. So here, so whenever we have an intubated and the patient, so we should see the tube size, if at all, because the patients with obstructive and airway diseases, so needs a bigger tube. So the tube size of around 8.5 will be adequate and for them, and the lip level position in every shift, and we should see because it might migrate inside or come out as well. The tip of the endotracheal tube should be confirmed with a chest X-ray for the medico-legal the reasons. And the auscultation bilateral from the air entry to be checked, and the ET secretions. If you have patient with more than 3 or 4 days on ventilator, in your assessment, in your monitoring, see for the secretions a color, the quantity, and the consistency, and look at the ventilator and the circuits, any secretions, the leak, the kink in the circuit. If at all, if you feel that a PIP is going about 30 or a 40, It can be because of the secretions in the circuit. If at all, if when the tidal volume is only 50, 100 ml, it can be because of the leak in the circuit. So, and we should know how to troubleshoot all this. And we should also be aware about the ventilator and the curves. So we will go with that. The types of in the waveform, the scalars and the loops. So whenever you're dealing with patient with a ventilator, then you should be aware with and the scalar and the loop. I'll not go in detail. I'll just touch upon on this. And the scalars is the whatever you plot against the time is a scalar. It is like pressure, volume, and the flow. All three. If it is time is axis and the y is the pressure and the volume or the flow. And the loops are, and there is no time component at all. See, here it actually deals us about inspiration and expiration time. So here the loop actually deals about the more of a and the lung parenchymal and the structural and the problems like compliance and the restrictive and the lung disorders. So the types of the waveforms, and the volume mode and the pressure mode to teach you guys under roughly in the volume mode, and the volume is actually constant. In the pressure mode, pressure is constant. With the support, pressure support, volume support, it won't actually reach the liquid baseline. Inspiration, the expiration actually starts in between. Here it is a control mode. After every cycling, it changes to expiration. So, and we should be aware of how to see the ventilator and the waveforms to know what exactly is happening with the patient lung. So the pressure and the waveform, if you see the peak inspiratory and the pressure, the plateau pressure, and the airway, and the resistance, and the alveolar distancing and the pressure. If at all, if you have to see for the compliance, it's more of an inspiratory hold, and see for the like P plat. If at all, if you want to like see for the airway and the pressure, it is like peak inspiratory and the pressure. So pressure volume loop, it's all with inspiration and expiration. If at all, if you find any that changes, if at all, if it is not reaching the like a baseline, it can be because of the leak or like bronchospasm and all that. So after all this, so we'll go the monitoring and assessment for and the sonography. Sonography is the one so which actually, so for us in our ICU in the Manipal, so it is like and the stethoscope, and for us for all the assessment of the patients. If my trainees are there in this talk, so they'll know our actually we are actually dependent on the sonography. Though we do all the examination and the clinical examination, our thought process is actually dependent on this. So the sonography and the assessment of the chest, especially see for the lung slide. If at all, if you can see in this image here, look at the pointer here, you can see the parietal and the pleura and the visceral and the pleura actually and the sliding each other. It is called when the lung slide. If at all, if this is absent, it can be absent because of the n number of the reasons. If it is absent, and if you can find out on the lung point, and the lung point is a point like where exactly, and you can see absence and presence of the point, the where exactly a pneumothorax and the starts. So, but if it, so when the lung point is a one which has got highest sensitivity for the and to diagnose a pneumothorax. So then comes other image here, and also here if you can see in the rocket lines, it is B lines which actually tells us about interstitial and the fluid in the lung parenchyma. And the consolidation, if you can see here, all the like a white, the plaques here, it's more of a air bronchogram. So if it is under dynamic, it goes in favor of infections. If it is under static, it goes in more favor of atelectasis. The pleural effusion you can see in this on the diagram. So with on the liver on this side, and the diaphragm, pleural effusion, and the lungs. And to rule out the causes of the hypoxia, so we know blue protocol. So it is blue protocol is not used in all ICUs. It is like more of a emergency diagnosis. If at all, if you have like patient in your emergency, to and the rule out cause of the hypoxia, to make our approach in a like a better way, blue protocol it can be used. But until and unless if you know the thorough examination of the patient with added advantage of the radiological investigation, blue protocol is not required for all the patients. And yeah, so patient with on the normal slide of the lung, the seashore sign, if at all, if there is any pneumothorax, the barcode sign. So then comes the blue protocol. Here we can see with the lung sliding and the present A profile or on the horizontal lines in the same field. If it is on B profile, it's more of an interstitial and the fluid. It goes in more favor of the pulmonary demand. A profile, so it's not with interstitial and the fluid. It can be under vascular as well. So it's more of if you want to see any under thrombosed veins has a suspicion for the pulmonary embolism as well. And with abolished the lung slide, if the patient has on the B profile, it can be abolished the lung slide. It can be because of the dense consolidation. So the patient can have pneumonia. If you find the lung point, it's pneumothorax. So it's all about on the ultrasound of the chest. So I know, and then comes on the radiology. All this I'm just touching upon on everything for the monitoring and the assessment. On the chest X-ray, in ICU, the chest X-ray is required, though we do and ultrasound for all the patients. If at all, if you have to see for any patient with a ventilatory associated pneumonia to diagnose and the newer shadows and to send for to see for and the VAP scoring system. So you might have to send for the cultures to diagnose in the VAP. So you need a chest X-ray to see for the new shadows and to rule out acute conditions like in the pneumothorax, like post and the procedure, like a central line or the like post CABG. For all, if you find any in the pneumothorax or the hydropneumothorax or anything, so you might need a chest X-ray and do the like follow-up X-rays to see the difference and also the response to our treatment. And the CT scan to assess for the response to the pneumonia, non-resolving the pneumonias to see for any cavities or any long-standing the pathologies. So with all this about the monitoring, so now comes the respiratory support. I've dealt with most of the support already. On the clinical and the goals of this on the respiratory and the support is to treat hypoxia and to decrease and the work of the and breathing and also to decrease the myocardial and the strain. So we have a different delivery and the methods and the low flow oxygen methods and the high flow oxygen methods. The factors which actually determine so which device to be used, it depends on the patient and the comfort, amount of the FiO2 and the required, and the titration of the FiO2, and the level of the humidification and the nebulization, minimal and the resistance like breathing, and efficient use of oxygen. So whenever you're starting the patient on oxygen, so you might have to see all these and the factors. So nasal cannula and the low flow, it has nasal cannula, the simple and the face mask, the partial and the rebreather mask, and the NRBM. And the high flow, it's a Venturi mask. So it has got an oxygen flow. A nasal cannula, it's only up to around the 4 liters. Different in the school of thoughts actually tells up to like 6 liters as well. And FiO2, it can give up to like 0.24 to like 0.44. The simple face mask up to like 0.6. Partial and the rebreather up to like 0.7. NRBM up to like 0.6 to like 0.8. And the Venturi mask up to like 0.5. It is like most commonly used for the patients with like COPD. So if you see with this, if the patient on nasal cannula with like a flow of under 1 liter, it is more of FiO2 of like 0.24. If you take the room air FiO2 as like 0.20, with every 1 liter, it will be 0.04 will be increased. So 2 liters like 0.28, 3 liters like 0.32, 6 liters like 0.44. So Venturi mask and the slightly different, it keeps under varying. It starts with the 4 up to under 12 liters. So with all this, I think so I've touched upon most of the monitoring and the support systems, as I tell all my 100 trainees. So you might sit and read a lot about intensive care. So, but you will remember only 10% of what you read, 30% of and what you see, 20% of and what you hear, the 50% of and the both and what you heard now and the what you saw now. So if at all, if you have and heard effectively for like 40 minutes, and you might remember and only the 50% of my talk. So 70% and what we say, in the sense when you teach and somebody, you will remember around 70%. So and the 90% is of what and we say and do daily in your and the practice. So do bedside on clinical examination, and also on the assessment of the head-to-toe examination for any patient, and spend a lot of time on the like a bedside to do the assessment, and also see for all the variables like the ISPO2 and ETCO2 and ABG, chest X-ray, the CT scans. So that's all. So on the take-home message, the clinical examination is like a best method of in the monitoring, if at all, if you ask me, and the know your and gadgets well, and the working principle, the usage and the limitations. The treat the patient, not the number on the reports. Understand the like principle behind oxygen and the delivery devices. So thank you.